Okay. Good afternoon, everybody. So today I'm just going to go over a brief overview of what chemotherapy is, why it works, and what specifically we're looking at targeting when we use different chemotherapeutic drugs. I'll go over some of the basics of chemotherapy, what drugs we look at, where they target, and I'm also going to discuss a little bit about biotherapy or targeted therapies, which is really where most things are moving in oncology. And so the objectives are to describe what the cell cycle is, and just as a reminder in relation to the cancer process, to describe chemotherapy and biotherapy principles, to identify chemotherapy and biotherapy agents as well as their mechanisms of action, and then to describe standard of care that we use. And so if we think about cancer and what cancer specifically is, it's a disease of mutations. And so it's a disease where cells are able to grow without any signals to prevent them from growing, where cells are insensitive to anti-growth signals, where there is tissue invasion, where there is metastases, where there is this endless replication, and therefore cells are able to grow, and that's what tumor mass is essentially. Its sustained ability to promote and achieve its own sense of angiogenesis or blood vessel growth, and it essentially is able to evade the apoptotic signals or prevention of cell death. And so if we think about systemic cancer therapy and what our goals of therapy are, one is the action of chemotherapy, and these agents could either be cytotoxic, which means they disrupt the cell mechanism and function, and they cause cell death. The other option is to be cytostatic, which is to alter growth and division. Or they could be nonspecific and affect the cancer cell without us really knowing the mechanism of action. When we look at biological therapies and actions, these are targets that are either going to affect growth factors, they're going to affect angiogenesis, they're going to affect the immune system, or they're going to have specific targeted effects on specific targets, whether or not we know what these targets do in the cancer cell. And so as a very brief look at what the cell cycle is, it essentially is composed of different areas, and essentially what you have also built into this is a cell cycle and the cyclin-dependent kinase complex. And moving quickly, what we essentially have is the role of how cancer in the cell cycle plays a role. And so oftentimes within the cell cycle, there will be mutations occurring. And the question is, does your body prevent these mutations from continuing to go through the cell cycle and promote these cancerous cells and tumors? Or is there a checkpoint at which point you'll notice that there's potentially a chromosome abnormality and therefore the cell will die as opposed to going through the cell cycle? Will there be an area where you say, is this cell able to go for division, yes or no? Is the DNA strands intact? And is there a role for a second inspection of the DNA? So essentially going through the cell cycle, we're hoping to promote normal cells only through this cell cycle. And so the chemotherapy principles is essentially to prevent cell division. And so a cancer cell gets through the cell cycle, it continues to grow. And essentially, if you're going to be cytostatic and kill the cell, and halt the cell from growing, you want to affect the cell division. And if you're going to be cytocidal, you're going to cause the cell to die. And so when we look at how do tumors respond, and that's the middle of the screen, essentially tumors will grow if they develop drug resistance. Let's see. And so if you have drug resistance here, the tumors continue to grow. If you have a very large tumor burden, sometimes it's harder for the tumor responds, and the tumor continues to grow. The rate of tumor growth affects whether or not the tumor is going to respond to treatment or not. Combination versus single agent therapy. If agents are synergistic and help each other out, they have a better chance of causing a tumor response and tumor shrinkage. If agents are antagonistic to each other, which obviously one never tries to have antagonistic treatments, but it has happened in clinical trials, then the tumors do not respond. You look at the dosing of the drugs you're using and whether the dosing are appropriate. You're also looking at dose intensity. So how often are you giving these drugs? Are you giving them daily? Are you giving them weekly? Are you giving them every 2 weeks, every 3 weeks, every 4 weeks? And then you also look at status of different receptors. Here I put up hormone receptor status. So chemotherapy causes its toxicities by the effects on the cell population. And so the bone marrow is a cell type that rapidly is changing over time, and therefore your chemotherapy toxicities is greatly going to affect the bone marrow, and the bone marrow is the maker of cells, and therefore it will affect your blood counts. It affects the gastrointestinal tract because of the cell population. your ability, or it causes sterility, and there's often hair loss because hair follicles are rapidly growing. And then there are specific drug-specific toxicities that you see, whether or not they affect the heart, whether or not they affect the lungs. It's specific to the mechanism of action of classes of drugs and drugs in particular. And so chemotherapy gets used in several different ways, depending on who we treat and how we treat, whether or not we're treating hematological malignancies or solid tumor malignancies. There are different concepts that come up. And so specifically, if you're looking for primary induction, you're wishing to do something to the cancer cells before definitive therapy, or you're trying to get them to go into some form of remission early on. Neoadjuvant therapy, it means you're doing something prior to a definitive therapy. So whether it's like neoadjuvant chemotherapy in breast cancer, you'd be giving chemotherapy prior to a surgical resection. Adjuvant therapy, and as in colon cancer or breast cancer, is when you add therapy after you've done your definitive treatment. So patient goes for surgical resection, and you would add adjuvant therapy in order to decrease the risks of a recurrence. Site-directed treatment, whether or not you treat as the specific therapy for the disease. And concomitant means you give it with something. Often this is in conjunction with radiation therapy. And so the role of chemotherapy and radiation, as in head and neck cancer, is curative intent treatment. And then you also have chemotherapy antidotes. So you're changing the mechanism by which the chemotherapy works, and you're sometimes adding particles in order to make it more effective and decrease some of the side effects. And then we also take into account chemotherapy safety, which is really looking at patients' education with respect to the side effects of treatment, as well as the healthcare personnel who is administering the treatment, because these are all toxic drugs for the body and have side effects to people that come into contact with it. If we look at classifying chemotherapy, and we're looking at all toxic therapies here, you have those that affect the cell cycle specifically, those that are non-specific to the cell cycle, and therefore it doesn't take into account where in the order of the cell cycle the tumor is replicating. And then you have some agents that are miscellaneous and a little bit different than the rest. And so the cycle-specific agents, you're going to have the antimetabolites, the antimitotics, and the topoisomerase inhibitors. In the non-specific agents, we have alkylators and antitumor antibiotics, and then procarbazine is in the miscellaneous box. And so if we look at the antimetabolites, these are a series of drugs that prevent synthesis of complementary DNA strands during the S phase of the cell cycle. The classic side effects of these include bone marrow suppression. We know that the way that the drugs work, you usually see suppression about 7 to 10 days after initiating a drug therapy. And usually by the 21 to 28 day mark, the suppression is gone. It causes inflammation in the mouth and throughout the GI tract. It causes diarrhea because of some of that. Nausea and vomiting, and they also could serve as radiosensitizers. So if you give them with radiation therapy, you could accentuate the effects of radiation, but also the toxicities of radiation. And so when we look at antimetabolites, we have a number of drugs, both oral agents and IV formulations that we use, and they cross the barrier of a number of disease sites. So capecitabine is an oral agent used in tumors of the GI tract as well as breast cancer. Cladribine, cytarabine for the hematological malignancies, as well as fludarabine. Fluorouracil is a very old drug used in GI malignancies, head and neck malignancies as well. Gemcitabine is used right across the board, including lung cancer. Hydroxyurea could be used for head and neck cancer, could also be used for non-malignant diseases like sickle cell disease. Mercaptopurine, methotrexate, is a very old drug used right across the board in oncology, but also used in rheumatology for rheumatological illnesses. Pemetrexate, a relatively newer drug approved for lung cancer, pentostatin, and thioguanine. When we look at the antimitotic agents, we could classify them in the vinca alkaloid or the taxane categories. In the vinca alkaloids, we think vincristine, vinblastine, vinorelbine, all sound about the same, which makes it easier to classify them. We have the taxanes all ending in similar names. So we have docetaxel, paclitaxel, or newer formulations of paclitaxel. Right across the board, agents that work in a multiple number of different illnesses, both hematological and solid tumor cancers, as well as right across the board, lung cancer, breast cancer, head and neck cancers. There are different classes of drugs. The topoisomerase inhibitors, very interesting class of drugs, came about in the treatment of, and essentially has revolutionized the treatment of colon cancer, and then also drug topotecan used in gynecological malignancies as well as lung cancer. And then there's the topoisomerase II inhibitors, including etoposide, doxorubicin, daunorubicin, and arsenic trioxide used in leukemia. When we look at miscellaneous cell cycle-specific agents, we're looking at asparaginase and pegaspargase used in leukemia. For the cell cycle non-specific drugs, we're looking at antitumor antibiotics, actinomycin D, bleomycin, mitomycin, mitoxantrone, doxorubicin, daunorubicin, epirubicin, idarubicin, liposomal doxorubicin, very common drugs that are used right across the board, whether it's used in leukemia, breast cancer, testicular cancer, so a number of different uses for these drugs. The alkylators are an interesting class and certainly have, as a class, a great use in a number of tumors. Have really changed the landscape. If we take a drug like temozolomide, which is an oral agent alkylator, completely has changed the treatment of glioblastoma multiforme, which is an aggressive form of brain tumor. If we take drugs like oxaliplatin, has changed the landscape of the treatment of colon cancer. Ifosfamide for sarcomas and lymphomas. BCNU and lomustine for brain tumors, carboplatin and cisplatin, very common for head and neck cancers, lung cancers. Cyclophosphamide used right across the board, whether it be for breast cancers, lymphomas. So all of these are very non-specific drugs. The mechanism of actions really attack the cancer cells because of the way that the cancer cells are dividing. As we move across the board away from to hormonal agents that aren't traditionally considered chemotherapeutics because they actually are attacking certain targets, you could have anti-androgens, anti-estrogens, luteinizing hormone, releasing hormone analogs as well. And so these are used right across the board in a number of tumors, most common being breast cancer, as well as prostate cancer, so hormone-driven tumors typically. And if we move over the last several, or at least the last decade, the push has really been to go from more or less specific to more specific. And what we're essentially trying to do is create biological agents. So these are agents that will attack certain receptors that we're aware of what the receptors are. Now, whether or not the receptor drives the cancer cells is uncertain. And so a tumor may express a receptor, but this receptor may not be responsible for why the cancer is aggressive. And so what essentially happens is that you end up with we'll start with monoclonal antibodies, and essentially what you do is you inject a mouse model with an antigen. You're going to end up creating these fusion proteins, and essentially you're going to harvest out monoclonal antibodies from them. And when we take antibodies, you have the antigen binding site at the top of the antibody, and you're going to end up with the light chain and the heavy chain for the antibody. And we move to, when we discuss monoclonal antibodies, you then want to be able to categorize them all right across the board. And so the way that their names are, if we look at a generic name for any drug, it helps you understand what the drug is composed of. And so it could either be completely human, it could be murine, it could be a chimeric combination, or it could be humanized. And depending on which type of antibody it's going to be, essentially what you're going to achieve then is the last 4 or 5 letters of that drug is going to be called accordingly. And so any drug that ends in umab is going to be human, any drug that ends in momab is going to be murine, zimab is going to be chimeric, and zumab is going to be humanized. And so monoclonal antibodies have several functions, and they serve several purposes. They could be cytostatic. They have an antibody-dependent cell-mediated cytotoxicity, and so independently they have the ability to cause some form of mediated response, which helps the cells die. There is a complement-dependent cytotoxicity, and they could directly induce apoptosis or cell death. They could also be additive as a radiosensitizer. And they could also release inhibitory checkpoints to help the cell die. Conjugated, they could be attached to a toxin or a radionucleotide. And so they could end up being naked antibodies or conjugated antibodies. And so if we look at unconjugated monoclonal antibodies, we're looking at drugs like Rituximab, which is the first to come to market, Cetuximab, Trastuzumab, Bevacizumab, Panitumumab, Alemtuzumab, which are all currently FDA-approved drugs used for the treatment of malignancies. So Rituximab is the first antibody for cancer treatment. It targets a certain antigen, the CD20 antigen, and therefore its indication is for any Hodgkin's lymphoma tumor that has a CD20 antigen that is positive. And so these would be for large cell lymphomas, diffuse or low-grade lymphomas as well. Because of the mechanism by which some of the rheumatological illnesses function and you're affecting the immune system, some of these drugs have been tried in different diseases, and Rituxan has been tried in diseases like rheumatoid arthritis. It's also been tried and used in non-malignant hematological conditions like ITP, where there is some data for its use. Alemtuzumab is a target of CD52, so a little bit different than Rituximab, and therefore it only targets cells with CD52, and you would attack diseases that are driven by CD52, which is a BCLL. The adverse effects of this drug could include edema, asthenia, infections, and myelosuppression. If we move to look at different classes, we can't ignore the epidermal growth factor receptors. And so these are very important receptors that sit on cancer cells and may or may not drive the cancer cell. And so we look at epidermal growth factor receptor 1, 2, 3, and 4. HER is the other name for it, and EGFR2 is often referred to as HER2. And so drugs that are on the market, Trastuzumab, which is a target of HER2, and Cetuximab is a target of EGFR1. And so Trastuzumab targets HER2, and it has the ability to both affect extracellular, transmembrane, and intracellular domains, and therefore is exceedingly effective for tumors that express HER2. Having said that, tumors that express HER2 that respond to treatment with Trastuzumab are tumors that are driven by the HER2 receptor. And so tumors that express HER2, but HER2 isn't the driving force by which the tumor gets its malignancy and its proliferation from, using a drug like this doesn't actually work. Whereas a tumor like breast cancer, where HER2 is very important, in about 25% of breast cancers, HER2 is commonly used in the metastatic setting as well as in the adjuvant setting. And therefore, once Trastuzumab came to market, the way we evaluated breast cancer completely changed. And what essentially has happened that all breast cancers need to be evaluated for HER2 overexpression. About 10 years ago, breast cancers may or may not have been evaluated for HER2. It was a very expensive test. The testing modalities were uncertain, so some people did one way, some people did another, and it was very hard to make sure we were all speaking the same language. But essentially, once this drug came to market and we knew the effects of it based on clinical trials, that standardized the mechanism by which we test for and evaluate breast cancer. And so it is FDA indicated for adjuvant therapy as well as for metastatic disease. Side effects include infusion reaction, as well as over time you could end up with some cardiac problems from it, often related to the fact that these are the same patients that get chemotherapeutics that cause cardiac toxicity as well. Bevacizumab is a different type of drug. It targets the vascular endothelial growth factor receptor, and so it affects it as a ligand, so it's anti-angiogenic, and currently is indicated for colorectal cancer. There is an indication for breast cancer, however, this is being reevaluated by the FDA. There is an indication for non-small cell lung cancer, for renal cell, and for glioblastoma, which is a brain tumor. So the adverse effects of this drug is that it could cause hemorrhage because it's essentially affecting blood vessels and new blood vessel formation. It has been shown in clinical trials to cause gastrointestinal perforation, and so there are some serious side effects. So you truly want to make sure you have a good benefit before you expose someone to this. It could affect arterial thrombotic events. It could lead to clot formation. You can't take someone to surgery, and so the concern is if you have someone on this drug and they need a surgical procedure, you need to often wait 2 to 6 weeks before that surgical procedure. If you need an emergent surgical procedure, you could potentially end up with multiple bleeding complications from the drug. It can leak protein out through the urine, and it could also cause blood pressure to rise, which needs to be treated. When we look at conjugated monoclonal antibodies as opposed to unconjugated naked ones, here we start looking at things like drugs like Zevulin, which is an yttrium-90 addition to the antibody, and that targets CD20, the same as what we said about Rituximab. We have Bexar, which is also a target of CD20, which has an iodine-131 attached. You have Gemtuzumab, Mylotarg, which targets CD33. And the major side effects of these drugs are myelosuppression. When we look back at the epidermal growth factor receptors, again, we had Cetuximab as the target for EGFR1, which is HER1. This is indicated for metastatic colorectal cancer, for squamous cell carcinoma of the head and neck. And then also you break out that after being approved for colorectal cancer, it really got looked at, is there a subset of colorectal cancers that it's maybe better for as opposed to all comers? And you can test for KRAS wild type mutation, and non-mutated patients would benefit from Cetuximab. The side effects include a rash. There are receptors on the skin as well, and that's sort of a class effect. And you could also have an infusion reaction. You could potentially have death from an infusion reaction. Panitumumab is also an EGFR inhibitor, again causing rash, infusion reactions, could cause diarrhea. Both drugs leak magnesium from the body, and therefore it becomes a major side effect. And often a prohibition to treatment is the fact that you can't maintain magnesium levels in the body high enough to treat. Could cause nausea and vomiting, and this is a drug approved for colorectal cancer. Lapatinib came to market probably about 5 to 7 years ago. And this was one of the first dual inhibitors, and it was really the establishment of the ability to target two targets at the same time. You have EGFR1 and 2, or HER2, and it was tried, of course, in breast cancer where EGFR is a big target. Of note, trials looking at EGFR1 in breast cancer have not shown any benefit, probably because this receptor doesn't help drive the cancer and the malignancy. So it is FDA approved for metastatic breast cancer. It does, again, as a class effect, cause the rash and diarrhea. The other group of drugs which are oral agents are tyrosine kinase inhibitors. And these regulate cell growth and differentiation. And so essentially what happens is you have mutation or overexpression of certain receptors which cause cells to proliferate, the angiogenesis, resistance of cell death, they metastasize, they invade, and what you try to do is you inhibit the intracellular domain, which essentially turns the cell on. And so a ligand is now able to attach to the cell. There's no blocking of the ligand, which the antibodies do. This time what happens is you prevent phosphorylation of the cells from the intracellular domain, and all drugs in this class are ending in INIB, which is being able to tell whether or not this is a tyrosine kinase inhibitor versus a monoclonal antibody. And so Lapatinib is the first one to come to market. It's approved for non-small cell lung cancer and pancreatic cancer. It targets EGFR1 and the tyrosine kinases associated with the epidermal growth factor receptor. Its metabolism is important because you have to look to make sure that you're not doing anything that will either cause a blocking of it in the system or actually promote it that will make it more toxic. Gefitinib was the first one tested on the market. It was actually brought to market quite quickly from the FDA when it was first tried in a lung cancer study. However, on subsequent studies and larger studies, it was found to be not beneficial and therefore is not approved in the US. And therefore, only patients who were previously on it could remain on it. But it is approved in Japan and used readily. And then Imatinib, which is indicated for CML as well as GI stromal tumor, myelodysplastic myeloproliferative syndrome, Philadelphia chromosome positive acute lymphoblastic leukemia. This one has multiple targets, and depending on what it targets is essentially what's driving the cancer. And so BCR-ABL is the target of CML, whereas c-KIT is the target for GI stromal tumors. And so GI stromal tumors carry mutations in the c-KIT and KIT, which essentially drives the cancer cell. And so by blocking c-KIT with this drug, you block the cancer from growing. Dasatinib is a multi-target. It targets BCR-ABL, so again used for CML as well as Philadelphia positive ALL. c-KIT, so trials are being done in GI stromal tumors. And then it also is looking at PDGF6, and therefore any tumors that express this or think that this may be a driver of the tumor would have this as a potential drug of choice. Sorafenib is a multi-targeted agent, so we moved from individual targets to multi-targets. This one's targets VEGFR2, PDGFR beta, RAF kinase, and is approved for renal cell and hepatocellular carcinoma. And then sunitinib, which again is targeting multiple VEGF, PDGFR alpha, c-KIT. So naturally, this will play a role in GIST because of the KIT and PDGFR alpha, and then renal cell because of the VEGF inhibition. I think Dr. Gordon did go over bortezomib, and so maybe I'll skip that one. Another class of drugs we look at is immunomodulator agents. So we're looking at thalidomide, came back as an interesting drug about a decade ago, lenalidomide, and these are used for multiple myeloma and myelodysplastic syndromes. And then there are cytokines, which include interleukin-2, indicated for renal cell metastatic melanoma. These cause flu-like syndromes, capillary leak syndromes. A drug like interferon, which is used for a number of leukemias, as well as Kaposi sarcoma and melanoma. And then in all of these drugs, the chemotherapeutics, because they're causing myelosuppression, we look to really how do we stimulate the bone marrow in order to prevent some of the side effects and be able to treat patients with these drugs without having side effects that prevent treatment. And therefore, you could stimulate red cell production with EPO. You could stimulate white cell production with granulocyte colony stimulating factors. And so when we look what standard of care is, you have a number of drugs, a number of targets, a number of agents that can be affected. Essentially what we do in oncology and hematology is we go to clinical practice guidelines, which are created based on clinical trials. Most of them are phase 3 clinical trials for large tumors, phase 2 clinical trials for tumors that affect fewer patients. And essentially this gives a guideline for cancer treatment by site. It gives guidelines for how to detect tumors, how to prevent them, how to decrease risk. It gives guidelines supportive care as well. And there are also through the American Society of Clinical Oncology, the American Society of Hematology practice guidelines as well. And I'll take any questions anyone has. Yes?
There is a theory that cancer stem lines, which has a slower cell cycle, and probably
So I'm having a hard time hearing. Sorry, repeat that.
I'm asking about the theory of stem cancer cells that has a slower cell cycle and probably is chemotherapy and potentially populated tumor. So, I mean, what's the, is there any specific class of agents that would be more adapted to such cells?
So if I'm understanding correctly, so you're asking, are there tumors essentially that because they're growing at a pace that sort of avoids the cell cycle, they're not going to be affected by chemotherapeutics? And so there are a number of tumors that we know that we can't use chemotherapeutics for. And so everything really changed and got revolutionized with the use of targeted agents. And so targeted agents specifically target receptors on the cancer cells and therefore don't rely on the cell cycle. And so tumors that are exceedingly slow growing cannot be affected by chemotherapy for the most part. And that the ones that bypass the cell cycle obviously can't as well. And then the other thing is the addition of radiation therapy, which the next lecture is going to be on, certainly plays a role in these tumors as well. Someone had a question up there. Yes?
Do you know if anyone at Northwestern is looking into electroporation as a means of increasing the uptake of chemotherapeutics?
I'm not familiar with that. I'm not familiar. No further questions? Thank you very much.